preload, afterload, contractility. These are the three determinants of stroke volume, and students mix them up constantly. Let's pin them down. Preload is the degree of ventricular stretch at end diastole. Technically, it's wall tension right before contraction begins. In practice, we approximate it by end-diastolic volume. Clinically, we estimate preload using surrogates: central venous pressure for the right ventricle, pulmonary capillary wedge pressure for the left ventricle. Anything that increases venous return, fluids lying supine, venoconstriction, increases preload. Anything that decreases venous return, bleeding, diuretics, vasodilators like nitroglycerin, decreases preload. Afterload is the load the ventricle must overcome to eject blood. For the left ventricle, this is roughly aortic pressure, or more precisely, systemic vascular resistance. Laplace's law tells us that wall tension equals pressure times radius divided by twice the wall thickness. So afterload rises when pressure rises, when the ventricle dilates, or when wall thinning occurs. Hypertension, aortic stenosis, and vasoconstriction all increase afterload. Vasodilators, ACE inhibitors, ARBs, hydralazine, nitroprusside decrease afterload. Contractility, also called inotropy, is the intrinsic strength of contraction, independent of preload and afterload. You can think of it as how hard the ventricle squeezes for any given end-diastolic volume. Contractility rises with sympathetic stimulation, catecholamines, digoxin, and elevated calcium. Contractility falls with beta blockers, non-dihydropyridine calcium channel blockers like verapamil, and diltiazem, acidosis, hypoxia, ischemia, and a dying heart. Now the Frank-Starling law. Within physiologic limits, the more you stretch the ventricle, the harder it contracts. Why? Because the sarcomere has an optimal length, about 2.2 micrometers, where the overlap between actin and myosin filaments gives the maximal number of cross bridges. At shorter lengths, the filaments overlap too much and physically interfere. At longer lengths, they pull apart and fewer cross bridges can form. As the ventricle fills and stretches, it's climbing toward optimal overlap. There's also a calcium sensitivity effect. Stretched myofilaments are more sensitive to calcium. The Frank-Starling curve plots stroke volume against end-diastolic volume. It rises steeply at first, then plateaus. In heart failure, the whole curve is shifted down and to the right. Any given preload produces less stroke volume. And importantly, a failing heart may sit on the plateau, where extra fluid doesn't boost output and instead causes congestion. This is what makes preload dependence clinically important. A hypovolemic patient is on the steep part of the curve. Every 250 milliliters of fluid you give bumps them up and increases stroke volume. A patient already maxed out on the plateau, or worse, climbing the pathologic descending limb of an overloaded ventricle, gets nothing from more fluid except pulmonary edema. Clinical anchor: in septic shock, patients are vasodilated, so systemic vascular resistance, afterload, is low. Their ventricle is underfilled because of vasodilation and capillary leak, so preload is low. Stroke volume falls. Step 1 is fluid resuscitation to refill the tank, increase preload. If the patient doesn't respond, step 2 is vasopressors like norepinephrine to raise afterload back toward normal. If the heart itself is weakened by sepsis-induced myocardial dysfunction, step 3 may be inotropes to increase contractility. Hypertensive urgency works the opposite way. Sky-high afterload means the ventricle is struggling to eject. Stroke volume falls, pressure backs up into the pulmonary circulation, and the patient develops flash pulmonary edema. Afterload reduction, intravenous nitroglycerin, nitroprusside, or labetalol unloads the heart and the patient clears their lungs. Preload fills the pump. Afterload is what it pumps against. Contractility is how hard the pump itself squeezes. Keep those three straight and you can reason through almost any shock state.